All right, let's get right into it. Today, we're going to tear down one of the biggest myths in all of medicine, a myth that's been burned into our brains by decades of TV dramas. We're going to uncover the surprising and honestly, sometimes unsettling truth about the drugs we use during a cardiac arrest. So let's jump in. You know the scene, right? You've seen it a million times. The monitor goes flat. Beep! The heroic doctor screams, "Push one of epi," and like magic, the heart starts beating again. But is that real? Can a shot of medicine actually restart a heart that has totally stopped? Well, the answer from science is a clear, simple, and absolute no. There is no drug in the resuscitation toolbox that can magically restart a flatlined heart. So if it's not the drugs, then what are the real heroes of this story? The real heroes of resuscitation aren't found in a syringe. They're physical. It really all comes down to two things: really good, high-quality CPR and getting a defibrillator on the chest for an early shock. The drugs, they're just the supporting cast. And you can see exactly where they fit in when you look at this hierarchy of survival. Everything that really matters is right at the top: recognizing there's a problem, starting chest compressions immediately, and shocking the heart if it's needed. And then, way down at the bottom, in fourth place, that's where the drugs come in. They're a part of the process, for sure, but they are not the main event. So, okay, let's talk about the big one, the drug everyone knows, epinephrine. You might know it as adrenaline. For more than half a century, it's been the absolute cornerstone of trying to save a life. But what we're learning now is that it comes with this terrible trade-off, a real double-edged sword. You see, epinephrine basically has two completely different personalities. On one side, you've got the squeeze. Now, this is the good part. It's what's called the alpha effect, and it clamps down on blood vessels to shove whatever blood is moving towards the two organs that matter most, the heart and the brain. But then, there's the kick. This is the beta effect. It basically whips the dying heart muscle, forcing it to work harder and burn through oxygen it desperately needs and just doesn't have. And that can actually cause more harm. So for decades, we just kind of accepted this deal. But then, in 2018, this huge, groundbreaking study called the PARAMEDIC-2 trial finally asked the question everyone was a little afraid to ask. Does giving epinephrine actually work? Does it lead to better outcomes? And when the first results came out, it looked like a cautious yes. The patients who got epinephrine had a slightly better chance of being alive after 30 days. We're talking 3.2% versus 2.4% for people who just got a saltwater placebo. It's a small difference, but it's a difference. So case closed, right? Epinephrine works? Not so fast, because the researchers then asked a much more important question. I mean, it's one thing to survive, but what about the quality of that survival? What kind of life are these people going back to? What about their brains? And this is the finding that sent shockwaves through the entire medical world. Of the people who actually survived, the ones who got epinephrine had nearly double the rate of severe brain damage compared to the group that got nothing. We're talking 31% versus just under 18%. That's a huge, devastating difference. So why? What is happening here? Well, the leading theory is something called the microvascular clamp. Remember that squeezing effect? Well, it's great for boosting pressure in the big arteries. It might be clamping down so hard on the tiny little blood vessels in the brain that it literally starves the brain of oxygen. So you're saving the pump, but you might be sacrificing the computer. Okay, let's shift gears and look at the other big category of drugs, the antiarrhythmics. These are the ones we use for what we call shockable rhythms, where the heart's electrical system has just gone haywire. It's pure chaos. These drugs are designed to try and tame that electrical storm. Now, it is absolutely critical to understand what these drugs actually do. Just like epinephrine, they do not restart the heart. Their one and only job is to calm down that chaotic electrical noise just enough to make the heart more likely to respond to the real fix, that big electric shock from the defibrillator. And the two main players on this team are amiodarone and lidocaine. A good way to think about it is that amiodarone kind of forces a timeout between each of the heart's crazy electrical signals. Lidocaine, on the other hand, is a bit more targeted. It muffles the most irritable, angry heart cells that are causing all the trouble. For years, there were huge debates in medicine about which one was better. Well, another massive trial finally gave us the answer, and it was pretty humbling. It found that for most patients, neither drug was any better than giving a placebo. They only seemed to help a little bit if someone actually saw the person collapse and help got there super fast.
And the biggest takeaway of all, there was zero difference between amiodarone and lidocaine. They worked exactly the same. All that debate was for nothing.
So all of this research, all of this science, it's pointing to this really powerful new way of thinking. In resuscitation, sometimes doing less is actually doing more. Let's take a look at a couple of what you could call the fallen heroes, drugs we used to swear by that we've now abandoned because the evidence just wasn't there.
A perfect case study is a drug called vasopressin. For more than a decade, it was a popular alternative to epinephrine. The theory was great. You get all of that good squeeze without any of the bad kick. But then study after study showed it just didn't improve survival. So, in 2015, it was totally removed from the guidelines, mainly to make the whole process simpler and less confusing in a high-stress situation.
And remember sodium bicarbonate? We used to give it to fight the acid that builds up in the blood during an arrest. But it turns out it causes something called a carbon dioxide paradox. The chemical reaction makes a ton of CO2, which then rushes into the cells of the brain and heart, making them even more acidic on the inside. So now, giving it routinely is strongly recommended against. So, after all that, where do we stand? Well, we're left with a modern philosophy of resuscitation that's a whole lot leaner, a lot smarter, and way more based on actual evidence than it's ever been. We've moved away from just throwing the kitchen sink at the problem to an approach that's much more about precision and, frankly, restraint. And that really brings us to the single most important idea to take away from all of this. The true art of modern resuscitation isn't about memorizing a long list of drugs to push. It's about understanding the powerful evidence for why we shouldn't give something, and instead focusing all our energy on the things we know for a fact save lives: excellent CPR and early defibrillation.